So as I said before, we're going to hear some comments on these two presentations given by these three panelists. Great. So starting with you, Mark.
Yes, thank you. First, thank you for those excellent presentations, and also thank you to Richard and Chris. I think this is the only way I would ever get into the Royal Society, so I appreciate being here. I only have 5 minutes, so I just want to make 4 key points, and actually they relate more to what we can do or could possibly look as next steps to the data. The first point, and this has been made already, is that data matter. And what's been most exciting in global health over the last 10 years to me is the use of data to change policy. And so how do we use these data and what could be done with the data that are buried beneath these data that could help drive policy? And that's not just happening in the UK. Richard mentioned that they met with the UK. It's happening in very exciting places that might surprise people, especially in Africa and sub-Saharan Africa. Her Excellency, the First Lady of Zambia, is here today, and it's remarkable when you go country by country and how ministries, ministers, heads of state are looking at data to make their decisions. And so it would just be a plea to the authors to make the data beneath what was published available and as rapidly as possible, country by country, disease by disease. What do the graphs look like? What's happening with HIV mortality? What's happening with child mortality, country by country, and publish it so that, or don't publish it, but at least give it to the country so that they can compare where they are relative to others, because those trajectories matter. And then the next piece of it, which would require more work, is what were the interventions that we can at least correlate with the changes in those graphs or lack of changes in those graphs, so that people can use the data that you already have or collect more data on the interventions so that the data can lead to decision making. Second major point, and this I'm sure the others will mention as well, is the importance of non-communicable diseases and how we've got to stop looking at averages, including globally, which is why those country by country things matter. Where are communicable diseases causing huge problems and where changes occurred or not occurred, and where are the non-communicable diseases? And a plea to get rid of the awful term non-communicable diseases. Cervical cancer, which Her Excellency works hard, is very strong on, would be dumped in non-communicable diseases. It's a communicable disease. It's caused by a human papillomavirus. Secondhand smoke is a communicable disease as far as I'm concerned, yet we put it in non-communicable diseases. So if we can get better about our language and try to understand it better, it would lead to my third point, which is how do we best link all these diseases together so that we policymakers can use the data to implement programs that will promote the health of people for the longest period of time, which would reduce that years of life lost. Because people who have HIV will eventually, if we keep them alive long enough, get diabetes or get hypertension. And how do we keep people alive for the long term, which means linking the diseases together. Another article that's in Lancet by Peter Piot, Michelle CDB, and myself is that AIDS is not over. It is not over, and the data presented today show us neither is tuberculosis and malaria. But the massive investments in those and the health systems that have been built to respond to those can be used to take blood pressure, can be used to look at diabetes. Doesn't mean the money comes from the same pot, but we can leverage and build off, and the more we have the data and the more we know where the diseases are crossing, the more we can actually link up interventions, and not with the same money, but leverage the money so that we get a better return on investment across the board for the health of people. Fourth point is the importance of the non-health sector for health. And I think these are what the data are showing us. Any intervention related to health, whether it's antiretroviral treatment or smoking, requires non-health sector actors to have the highest success. And the more we stop thinking about the health sector as the end of where we do health interventions and think about how the non-health sector and health sectors link, the better we'll do at serving the health of people rather than individual diseases. So with that, I am going to stop because I'm probably pretty close to 5 minutes.
You are, just 5. Well done, thank you. George.
Great. Thank you very much. Your Excellency, Sir Richard, ladies and gentlemen, I'm George Mensah, and I had the real pleasure of serving as the chairman of the Cardiovascular Diseases Expert Group since 2007. And it's really a pleasure, and I want to thank the Lancet and IHME for the invitation to participate in this session. In the interest of time, I'll frame my comments around three key messages. And the first message, which may sound strange since this is a panel on death, is there's actually real good news from the data that we've seen this morning. And the second message has to do with the fact that even though there's very good news, there really is reason for concern and a real reason for alarm. And I'd like to end with a simple message that these data actually also provide a real glimmer of hope as we move forward beyond this landmark presentation today. So what do I mean by the good news? First, several of the speakers have mentioned before, but the fantastic collaborations that have been built that made these data possible really deserves praise. In fact, if you look at cardiovascular disease alone, some 68 experts from around the globe came together to make this possible. So whenever you have more than nearly 500 experts from 50 countries and more than 300 institutions, this is really tremendous. And I hope this collaboration stays and drives the translation of these data into real actions. The second piece of good news is that there really has been substantial progress in spite of the death numbers that we've seen. In many countries and in many of these regions, there's been real substantial progress in preventing death from the major killers. In fact, if you look at the age-adjusted death rates as seen in one of the tables, in nearly all regions and in nearly all the cardiovascular causes of death, there has been substantial declines, even in sub-Saharan Africa. So this is really tremendous good news. Now, the second message about the concern is real, because in spite of the dramatic declines in death rates that we've seen here in the UK, and other parts of Western Europe, high-income North America, and Australasia, we still have heart disease and stroke alone accounting for 1 in every 4 deaths. In fact, if you look at all of the cardiovascular causes, they would account for 1 in 4 deaths, a substantial increase from the years before. But the real worry is that the vast majority of these deaths are coming in from low and middle income countries that can ill afford to treat these conditions. Another real worry, as we saw, has to do with the decrease in life expectancy that we've seen in the last decade in parts of Central Europe and Eastern Europe, as well as parts of sub-Saharan Africa, particularly Central or sub-Saharan Africa and Southern Africa. So these concerns should be taken into account as we think of moving forward. So given these two, why do I think there is hope? As you saw from one of the data shown, in fact, a very good reason for why these increases in deaths are happening has to do with the changes in population structure, in population aging, and certainly adverse lifestyle changes, really calling for a real investment in prevention. I think promoting healthy aging, beginning in children, with real emphasis on young adults and continuing through old age must be a real priority. Addressing population-level prevention must be crucial. Now, while individual treatment and control of these conditions certainly is important, we must keep the major word and emphasis on prevention. And finally, the data needs from many of these areas are really a challenge. In many of these areas, you can't even talk of ideal data. Very simple data are non-existent. And I hope that this landmark presentation today would really engender real interest from clinician scientists, from public health practitioners, from the general public, as well as policymakers into really investing in the approaches that will give us better data to make these estimates even more reliable. I think this landmark event coming within a year of the United Nations high-level meeting that gave us the political declaration, hopefully would really get all of us excited and create the political will to translate the data that we've seen today into real action to promote health and to save lives. Thank you very much for having me.
Thank you, George. Peter.
Yes, thank you, Pam, and good morning. Since I am one of the few people here who was not involved at all with the study, let me commend the whole team for what's truly a Herculean effort. And as we are in this August society, I think it's appropriate to compare this with what was one of the hallmarks of the Enlightenment, and that's the encyclopedias, that we're trying to understand the world in a holistic way. And this is what the global burden of disease is trying to do, I think, for health. 3 points on the data, and then some reflections on the future. I was surprised really by the speed of transition and the speed of change, both in terms of falling under 5 mortality, as we heard, but also the speed of transition in terms of chronic diseases. And I agree with Mark, anything that starts with none is a non-issue, so let's forget about non-communicable diseases, because it's clearly a big issue. But also, this disability transition that we'll hear more about later really challenges us in terms of the health services agenda, investments agenda in terms of research and so on. And my own ambition is to die healthy, so I think that's something we have a lot of work to do in that part of life. Secondly, I would say the great exception are all 4 regions of sub-Saharan Africa. They stand out as being different, and that means that there is still a huge unfinished agenda, and we should not forget that when we talk about the Millennium Development Goals in our Volume 2, where there is a trend to just throw away the current Millennium Development Goals. They're not achieved yet, and we should really continue to invest in them. And I think that the point that Mark made also, this AIDS is not over, but I think also there is a clear problem with young males in the world. And how to handle that, I think it's absent from all policies. Now, what about the future? First, I think we need to think about what I call GBD 2.0, Global Burden of Disease 2.0, and we can't wait for another decade to have the next version. I think there's a need for a kind of continuous update that I think will be more flexible also in terms of peer review, because I can't imagine how you review a set like that. I mean, I asked Richard Horton, how do you find people who can go through everything? It's not possible. But just a continuous update, which will be very important. Secondly, is that ideally each country should go through some exercise. Certainly bigger countries, I mean, where not only India and China, but as an entity, a national level is a bit absurd. Even we saw it in the Chief Medical Officer's report for the UK, huge differences within a single country. Thirdly, I think we need probably think through about some transparent mechanisms for review and reconciliation. Think, for example, of the whole debate about malaria data and deaths and so on. And that requires some further thinking. And I think I would like to commend Chris and Alan for what you've been doing in this in terms of partnership, but it can always be better. Finally, I think we need also a system that ensures global access to the raw data. You've put together an incredible database, and and I'm sure it can be mined even further, and how to do that will be another challenge. But I think that this global burden of disease is setting new standards in terms, not only in terms of health epidemiology, but probably also for assessing the metrics of other, let's call it, societal issues globally. Thank you so much.
Thank you, Peter. Right, we haven't got much time, but we've got a good 20 minutes. So I'd like to open up the floor for questions. I think the best way of doing this is perhaps take 4 questions at a time, and our respondents, our panellists here can respond appropriately. So questions, please. And there are speakers around the room, so you could have... Oh, no questions? That's interesting.
Nobody has read the paper.
Oh, there must be some questions, surely.
There
there's somebody at the back.
One hand.
Great, one hand.
Voluntarily.
Thank you. Please
Thank
do
you.
say who you are and who your question's directed to.
Thank you very much for the presentations. My name is Olga Golichenko, International HIV/AIDS Alliance. I would like to ask a question about the additional financing resources which can be available, for example, for addressing together HIV/AIDS and non-communicable diseases. Where can these resources come from, and how realistic it is that they would be available in the current economic crisis? Thank you.
Thank you. Richard. Question here down at the front, sorry.
I feel that I'd very much like to be able to play with the data, and I don't know how the data can be made available so that people can play with the data and try different approaches to them. You know, something between years of life lost and discounted years of life lost. How do things change as you put in a bit of discounting? Should one be discounting what is achievable by childhood mortality? It's reasonable not to, but it would also be nice to be able to just play with the data in various ways. And the relationship between disability-adjusted years of life lost and just years of life lost. To what extent does the introduction of the disability change any of the rankings? Is it that actually the key thing is the mortality and that the disability doesn't change the rankings very much on the major things? So I don't know how one can just get it so that you can just plot things in various ways, play around with it yourself, and then if you find that things really do change, or that you can get some new pattern out of it that differs from the pattern suggested by this publication, how could one... It's availability, it's just availability, transparency of this data set, because it doesn't need somebody else to do the data set again, but it might be that it would benefit from different ways of playing with it and trying to summarize it. I mean, the problem is how to summarize it, and I think just lots of people playing might produce something.
Thank you, Richard. There's a hand at the back there.
Hi, David Ross from London School of Hygiene and Tropical Medicine. I was just wanting to ask about the discounting and the age weighting, and how much have the changes from 20 years ago in the methodology changed the answers? And I assume, am I right to assume that any comparisons between the stuff from 1990 and the data from 2010 have somehow accounted for those changes, or they've been done in a similar way? Thanks.
Okay, thank you. There's another one there at the back. Oh, okay, we'll take this one and then we'll get some responses.
Hello, John Keel from Innovate Solutions. You mentioned the importance of individual countries doing their own studies. Will there be any software tools be made available to do this? It's just really how you could do that on a practical level, if there's going to be any assistance provided.
Okay, thank you. So the 4 questions were, in terms of finances, given this dual burden of communicable and chronic diseases, where are the resources going to come from? And then there was the question from Richard about how this data can be looked at and played with, and looking at the various differences between the effects of disability and years lost. And then the London School, there was a question there about discounting and age weighting, how the methods changed from 1990 to 2000, and then in country, how some of the GBD tools are going to be made available. So whoever wants to respond.
All right, I'll thanks very much for those. In fact, none of those questions are really germane to the presentation. So I'm in a wonderful position where I can dodge this and say, let's file these questions, because they're actually going to come up. I'm going to make an attempt at answering them, but seriously, they'll come up with every single presentation, because they're very generic and very clearly valid questions. And I think we really need to look to Chris Murray and to get his thoughts towards the end of the day about what he thinks would be done with particularly availability of data. Quite clearly, there's a massive amount of information here. We have published and presented by for the world, and for 21 what we think are epidemiologically sensible regions of the world. But there's clearly more detail. There's data there by country. As we mentioned, we spent yesterday working with the UK, who immediately saw the benefit in using these country estimates to input into their policy formulation and their dialogue. This is exactly what we want to see happen. But the availability of that information, and then coming back to Richard Peto's point about how does one have that information available in a way that one can play with it. These are perfectly valid, although I shudder to think how Richard Peto will play with it. But these are perfectly valid queries, and I really think this is something that Chris Murray, who's the mastermind of this and who in fact has the ownership of it, might want to respond to. But let's, if you will, allow us to work through the day and then come back to that, because I think that has implications for the dissemination and use of the study more broadly, not just in this session. So I'll dodge that question and flick it on to Chris for later in the day. David Ross's point, I thought I had made it clear, but let me say this again. This study supersedes anything else that we, or anyone else for that matter, has done on global burden of disease. The methods are strictly comparable. You can now compare 1990 with 2010. You cannot compare the Murray and Lopez 1990 version, which we're largely ashamed of now, but it was a good first attempt, with the 2010. You must take, David, internally within this study, that's where the comparability lies, and we've gone to great pains to describe and attempt to ensure that comparability. Chair, I won't address the issue of resources because that's not really a matter for scientists, but it's an important resource. I understand that question has two parts to it, and it comes back a bit to Peter Peart's point about data, and also what David mentioned, the clever ways in which we need, as a scientific community, to use currently existing platforms, as I understood that point that David made, to better collect information, more relevant information in a cost-effective way that will help answer questions of change in main causes of mortality. I think that's an extremely important point that we have not been very good at. But more generally, resources for addressing things like HIV and NCD, I think, is a policy discussion that I'd like us to come back to during the day, because what will become clear through this amalgam of presentations is that there are very clear priorities that are emerging based on our work and our findings that need urgent responses at the policy level, but also at the donor level.
Okay, thank you, Alan. I think Mark would like to perhaps say something about the policy implications regarding financing.
Yeah, and really I think the first question and the fourth question are related. It's true that we are in a financial crisis. No one would deny that. But that we're not poor. The world isn't poor. There actually is money around. The question is, can we use the money effectively? And that's what policymakers want to know. They'll put money out if we can show it will be effective and that it will save and lift up lives and make a difference for the future. And that's where the data become important. And I think it relates to two things. One is making the data available for countries themselves, which probably can be done within the data today. And I will be going to the Global Fund in about a month. I would love to host with PEPFAR, with DFID, with others, a meeting either individually with countries or collectively to run through country by country what you're seeing across the diseases, particularly HIV, TB, and malaria, because sub-Saharan Africa is where a lot of that's occurring, and also where maternal and child health fits into that. And then also look at how those platforms can be used to expand other services, probably for marginal cost, and do some work on what those marginal costs would be. Not that we would pay for it out of HIV, TB, and malaria funds, but working with those working on maternal health, working with those looking at long-term impact of smoking and diabetes and others, how we can build and leverage the investments that have been made for HIV, TB, and malaria for others. But it begins with the data. And if we can show people big impact for investment, money will be available. If we can't, we won't. So it comes to the data, and that's why it's so important. And maybe we can talk about how we could work together to ensure that those data do become available and policymakers can use them. The Global Fund's beginning a new funding model, which is totally focused on higher impact with the investments. And these data sets could help drive that.
Okay, thanks. George.
Mark, that's fantastic. I just wanted to say that I completely agree with what Mark has just said. But he began by saying that we are not poor. and that is true. But even in poor countries, I'm just reminded of something the former president of Nigeria, Obasanjo, said. Even in poor countries, we cannot wait until the economic conditions improve before we address these conditions, because they truly are all developmental challenges. And until they are addressed, it's not very likely that we'll make significant progress in getting out of poverty. So completely agree, and we're delighted you're going to the Global Fund.
When I said we, I meant all of us. Countries themselves, Zambia is increasing significantly their own resources for HIV this year as they did last year. Nigeria has resources. It's not just about ODA, it's about all of us together and financing, and they will invest their money if they see the data as well.
Raphael?
Yeah. So I want to make the point related with the comparison between 1990 and 2010, but not about the discounting. That's different. First of all, in 1990, the study from Murray and Lopez was 134 causes. We have 235 causes of death, but we expand for causes that don't kill, we have 291. They did a study for 5 age groups. We have now 20. They did a study for 7 regions. We have 21. So it's totally different study, and I really want to discourage this idea that we have to compare with the others. I'm sorry, Alan, but that's a study that is already passed, and now we have everything in the way that we can compare. So especially when we are talking about the solid data from causes of death. The other point that I want to mention is, and it is the importance of data is go beyond a declaration. It's good to have a declaration. It's good to have the commitment to collect data, but it's more important to act. And we have the tools to do that. We have to focus in collecting data, but we have to standardize the way to do that, and not just leaving the countries to go in the direction that they can do or they want to go. I think we are proposing in the study the way to standardize the quality of data, to measure the quality of data, and we can, again, do a continuous benchmark and trying to privilege which countries need that help and which countries are already good. Thank you.
Okay, thank you. Can I take some more questions? Yes, over there.
Yeah, Peter Smith, London School of Hygiene. In the last burden of disease, you actually made some projections as to what might happen in the future. You haven't mentioned that so far. Maybe it will come up in the rest of the day. Is that something you were hesitated to do this time, or is that something that we're going to hear about?
Thank you.
Tim Oliver, Bart's in the London Hospital. With diseases of addiction related to alcohol and tobacco still going up, is there any way other than prohibition to deal with it? Or, in other words, are these lessons for people who are talking about freeing other drugs of addiction onto the market to be similarly inducing further disease?
Okay, great. Oh, it's quite a few. There's one here in the front and one over there.
Jake Marcus, what did you think was the most surprising finding or result, especially results that would have been missed if the systematic and scientific approach wasn't taken?
Mickey.
Thanks. Yeah, Mickey Chopra. Alan, you pointed out the rapid revisions that both UNICEF and yourselves have had to do with the under-5 mortality estimates, and this is obviously, as you point out in the article as well, going to be becoming increasingly critical as we get to 2015. Any reflections on how we can try and ensure that by 2015 we have some convergence and some sense of where we're at in terms of at least under-5 mortality rates?
Okay, thank you. So I'll just get some responses and then we'll go around again. First question on the last burden of disease and projections of the future. Diseases of addiction, if anyone has a view on that and where we go with that. Surprising findings, what are the main surprising findings from this study? And Mickey's last point about rapid revisions between these various organisations and how by 2015 we ensure some kind of convergence of where we are at with under-5 mortality. So who would like to respond first? Alan?
Well, those are a series of minor questions, and I was hoping no one was going to ask that one, Peter, about projections, but since you have, I have to be honest. I hope it's clear from the size of the collaboration and the volume of output that it has not been a trivial exercise. What we have tended to focus on this time is trying to ensure that we had quality assurance mechanisms, given the vast amount of uncertainty that is inherent in this sort of exercise just because of the quality of data and the availability of data. So we've tended to focus, I think, much more effort this time on trying to do what we did, do it as well as we could, as opposed to expand the scope into areas where it would have added a substantial amount of additional work to the project. Now, when you go back to the 1997 study of the Lancet quartet that Richard Horton was bold enough to publish 15 years ago, the one that's cited the most is actually the projections paper. So it clearly indicates that there's a substantial demand in the global public health community for information on projections, and we can understand that. I think the plan, and I'll defer to Chris later in the day about this, but I think the plan is that projections will be done. Well, I know they will be done, but I think that's going to happen in the next 12 to 18 months. There's a couple of nodes of the GBD exercise that I'd actually like to come back to towards the end of the day, where we would like, for example, to be able to match country by country hospital expenditure, current health expenditure through national health accounts by disease, matching that to the burden by disease, and just seeing that mismatch and using that as a stimulant for policy dialogue. So there are important elements, Peter, that are not yet done in the study, but that are certainly planned for the future iterations of the whole burden of disease enterprise. Surprising results, I'll come back to prohibition in a moment, but surprising results, good question, Jake. I think the thing that struck me most, well, two things that struck me most. One was the speed of decline of child mortality, even in places like sub-Saharan Africa, or particularly in places like sub-Saharan Africa over the last decade. I was not aware of that from my reading of the literature. That in this exercise, that really came out as a standout result. That the MDGs, to some extent, are a distraction by focusing on our countries, will they or will they not achieve them. What we should be focusing on as a global community is how are countries doing recently in accelerating child survival, and I think that's what we're seeing evidence, and that was a surprise. The other big surprise for me in terms of mortality was the very substantial declines in adult mortality that we've been able to measure, particularly throughout East Asia, Southeast Asia, countries like Indonesia, Bangladesh. I don't know what they're doing, but they are certainly, we're witnessing from all the evidence we can assemble, significant declines in keeping young adults alive. Mickey, a question on convergence, I absolutely agree. I think there's a tremendous amount of collaborative opportunity that comes out of these studies. Remembering we're dealing with incomplete data, with poor data availability. We're dealing with different methods that scientists apply, and there's room for legitimate scientific disagreement in that environment. And we have a challenge, I think, not only to improve methods, but to improve data availability. And so I would like to think that convergence effort be seriously undertaken, but I do not think we should be trying to force consensus among scientists where there is legitimate scientific disagreement, and I may have some opposition to that. On prohibition, well, I don't think prohibition of alcohol is a great idea, and Richard Peter will have a lot to say about prohibition of tobacco, but I think more seriously, there are examples in the global community, and I'd like to think of my own country, Australia, and the work that Jane Holton and her colleagues have been doing, may hear during the day more about that, where tobacco prevalence is now down to 15 or 16% from 70%. So we are doing something right in some countries, and I think it's the lessons that we learn from those comprehensive tobacco and alcohol control programs and the way that we're bringing society along in these populations to see these practices as abnormal and unhealthy. Thank you.
Mark.
To Mickey's question, which I think is a really important one, is how we reconcile numbers, and not just on child health. We have the same issues around maternal health and other issues. I think about it more from a policymaker perspective. The numbers don't have to be exactly the same, but we need a narrative around them, which is, and I don't think the narrative is that complicated because all the numbers show the same thing. We've had significant progress, but we still have a long way to go, and we can't take our eye off of it. And it gets down to the regionality issue. You know, where are the areas where we're still having big problems? Why did we succeed where we succeeded? Why haven't we succeeded? And what do we need to get done? And not fight about, is it 7 or 6.2 or who cares, really, as long as we all have the same perspective and the same top line messages. And that's what's going to influence policymakers. If they hear us just arguing about the data, we're in big trouble because they're not going to want to hear it any further than that. And on addiction, I do think, I just wanted to come back to that. I agree with prohibition of alcohol or my life would be over. I do think it highlights something I raised, and I think we need to spend more time on, which is the non-health component of health. And, you know, addiction, whether it's use of people who use intravenous drugs, addicted or not, alcohol, those relate very much to HIV and tuberculosis. And it just highlights the non-health components of health. And we've got to get out of just physicians and public health experts and start talking about how we change norms and societal action and have, and that's true whether you do antiretroviral therapy where you need people to come in on a regular basis or whether or not you're getting people to sleep under bed nets as it is about addiction to disease. So we really need the non-health community involved in health if we're going to succeed.
Okay, thanks. Can I have Raphael and then Peter?
Well, I just want to address a question from Jake that I think is a very good point. First of all, I think we really didn't know many things about what we are presenting now. We didn't know the size of the problem of chronic kidney diseases, for example. And if we go to each government and we ask, what is the program that you have related with chronic kidney diseases, probably is going to be a big surprise. Nothing. So, and this is a big consumer of health services every day. And there are many things that are around there, the culture of transplantation, the typical diseases of diabetes or hypertensive heart disease. Hypertension. So we have here a new agenda to handle. The other thing is related with the role of hepatitis. It is, we always see hepatitis as a disease and is related with acute problems, acute deaths, and that's not true. Now we can prove the big amount of deaths that hepatitis can drive with cirrhosis, with liver cancer, and probably we can, if we add all of them, we can put in our list of millionaires from Lancet, because hepatitis is also a big contributor to deaths. And there are vaccines, but we have to revise carefully what are we doing with that. Another thing is we are in the second decade of the century 21st, and we still have a lot of deaths of pedestrians. It's a big shame for the society. It is one of the most important interventions from non-health system, as was pointed out before, are just put a sidewalk in the streets. But pedestrian deaths are at the same level of motor vehicle accidents. It's a shame. We didn't know that. We have to pay attention in that. Sometimes we see the bridge and the dogs take the bridge, and people don't take the bridge to cross the streets. That's important. And finally, I think the big agenda that we have with the youth population, it is we have to read carefully the last report of Bali, this week. In Bali was a big meeting of youth people, and they presented to us not old people talking about youth. That's the typical way. So I'm not old, and I can speak to you. No, I have to listen to you. How do you think about what are the problems that you have? And we have to read that report and try to understand, because we are not given opportunities. Youth people are dying by HIV, violence, are dying by maternal deaths, are dying by infections. And what are we doing in that? We are not given the opportunity. So this is not only a problem that we are having related with the causes of death. This is going beyond that and should be related with opportunities and human rights. So I think we have a very important agenda in that component, and this study is giving us that new idea that we didn't pay attention before. We go in the way of the Titanic, kids and women first. And we need also to include the youth in this agenda. Thank you.
Thank you, Rafael. Peter.
Yes, thanks. Also on Mickey Chopra's question, I think it's an important one. Whereas I agree that scientific debate is obviously healthy and necessary, that's how we make progress, public conflicts among scientists can be disastrous for policymakers. It turns away people and say, okay, if you can't agree, you technical people, why should we deal with it? And especially that in most cases, as Mark said, it's really much ado about nothing in the eyes of policymakers, and most debates are actually about disputes about figures that fall within the ranges of uncertainty anyway. But there are other issues. But so we had a big issue around that in the HIV world with wildly different estimates. I'm talking now about 15 years ago nearly, and much was related to poor primary data. And I think that's definitely the case for about everything we had. So what did we do? One, investing in better primary data collection. And try to reach consensus on how this data should be collected and can be compared. And I think that's, I think, going reasonably well. And secondly, to have mechanisms for, let's say, conflict resolution for peer review, without being politically correct, but say, the end of the debate could be we agree to disagree on this and that. And we may need other methods. And thirdly, to make sure that data are accessible, as Richard Peter said, that someone else can verify it, because that's also the basis of science. So I think we should be able to get there, but at the speed that under 5 mortality is declining now, the events may take over, maybe go faster than resolving the disputes among scientists. But I think that what is most important for, I think, policymakers are the trends, up or down, whatever, and then the whole issue that Mark mentioned in his first intervention, and that is how to relate that to to interventions, to results of the investments. And I think that's, from a policy perspective, that's what matters. But in the meantime, as this version of GBD is already so much better than the first one, the next one will be even better. However, the weak point, I think, is going to remain poor primary data. And the problem is, who's investing in that? I mean, that's what I thought WHO was supposed to do, and it's not doing. National ministries of health should do, and are not doing. And that will remain the Achilles heel of the whole enterprise. And it may be time that we just take that seriously and see how can we invest. We really did it for HIV, and I think it paid off, but it took about 10 years before I was confident.
Thank you very much, Peter. Well, we've run out of time, so I'd like to just say thank you to the speakers and for the very rich discussions we've just had. So a round of applause,
Well done, Senor.
Thank you.